morning, good afternoon, and good evening, colleagues, wherever you are located. My name is Dr. Folaranmi Ogunbowale from the Division of Healthcare Management and Occupational Safety and Health at the New York Secretariat, UN Secretariat in New York. Welcome to our Public Health Conversation series. And in today's series episode, will be taking us from smallpox to global health. From smallpox to global health, the historic role of vaccinations in protecting our lives. I mean, if we don't know, or if we are not familiar with the role of vaccination as one of the tools in public health to fight diseases, we could all see what happened during the COVID-19 pandemic, how a lot of vaccines were developed to help with the fight against the COVID-19 pandemic. So 2024 was the 50 years anniversary of the Essential Program on Immunization, a WHO-led initiative to bring vaccines to the whole world. So this talk for today, we look at the role that vaccines have had in reducing illnesses, saving lives, and improving livelihood over the last 50 years and beyond. And we'll look at the evidence behind these impacts from the fields of studies to mathematical models. And to help us do justice to this is Professor Mark Jeets. I will introduce Professor Mark Jeets to us now. So Professor Mark Jeets is an inaugural chair and a professor in the Department of Global Health and Environmental Health at New York University. He was formerly the head of the Department of Infectious Disease Epidemiology and Dynamics and co-director of the Global Health Economics Center at the London School of Hygiene and Tropical Medicine. He holds honorary appointment at the London School, as well as University of Hong Kong at the National University of Singapore. Dr. Jeet's research focuses on epidemiological and economic model of vaccines to support evidence-based public health decision-making. He has published papers covering a range of vaccine-preventable or potentially vaccine-preventable diseases, including COVID-19, measles, pneumococcus, rotavirus, etc. This work has influenced many of the major changes to immunization policy in countries around the world. Dr. Jeet has served as on a number of expert advisory committees in the UK, as well as for other international organizations, including the World Health Organization. He also organizes or contributes to academic and professional courses on vaccine modeling, economics, and decision science around the world. He receives his Bachelor of Science and PhD in Mathematics from the University College London, and he specializes in mathematical biology. Over to you, Professor Jeet. He will be taking us through the presentation. So after his presentation, then will be the time for question and answer. So along the course of his presentation, if you have any question, please do drop them in the chat box. Thank you very much. Over to you, Prof.
Great. Thank you so much for that introduction, Dr. Fuller. I seem to be having some problems with my camera, so you might not be able to see my face, but my slides are the main thing. So just making sure everyone can hear me okay, because that's the most important thing. If I don't hear from anyone, I'll assume I'm okay. So, excellent. Thank you so much. And thank you so much for the invitation to speak on this incredibly important topic about vaccination and the role it has played over the many hundreds of years in protecting our world. I'm really excited because I know I've been told there are people joining from all over the world, people in the UN and different UN agencies who are really part of the front line in protecting the health and safety of our world. So it's an honor to be able to speak to you about this topic. So I'm going to speak about vaccines, and what I'd like to start with is actually an article in The Economist, a news magazine, which I think puts it very beautifully, which said, in an ugly world, and I think if you work for the UN, you see some of the ugliness of the world, vaccines are a beautiful gift worth honoring. this is one of the shining lights in our world. Although sometimes it's not fully understood. I mean, they are immensely beautiful. They embody something beautiful, beautifully human in their combination of care and communication. They are not conspiracies or tools of control. They are molecular loving kindness. And maybe what I'm going to talk about over the next 40 minutes or so is to describe why they are that, that beautiful tool, what they have achieved, and some of the results from the work I do on modeling both epidemiological and economic modeling, health, and the way they improve the economy. I'm not going to go into the details of the models because I know this is a very general audience, but show you some of the results. But if you want to know more details, feel free to ask. So I'm going to start from the beginning. I said from smallpox to global health. So let's start with smallpox. I mean, the first vaccine the first modern sort of vaccine, I think different kinds of variolation, like protecting people from a disease using sort of like a killed version of a virus from the sort of like from people who have had the disease before. This has been practiced for a very long time in many cultures, including in the Middle East, in China, and so forth. But in terms of the first modern vaccine, this probably goes back actually more than 200 years ago to Edward Jenner, who many of you know this already, carried out the first smallpox vaccine, vaccinated a little boy with sort of like against cowpox, and that gave protection against smallpox. And from there actually was able to show that this gave sort of lasting protection against this disease. And so this was more than 200 years ago. But let's fast forward to a time in more modern history when smallpox was still around, but vaccination was still, had been widely used as sort of like a development of something that started in the sort of like late 18th century and then was sort of refined and improved over the years. In the year 1967, more modern, but, I don't know if anyone was alive then. I wasn't, but, recent enough that some people in the world might remember this. In the year 1967, smallpox had been eliminated in many countries of the world, but not in all countries. There were still 31 countries in the world with endemic smallpox, and this was causing 2 million deaths a year. And these were some of the poorest countries in the world. It was really not equitable. So in 1967, the world came together and said, this is a disease this is a virus for which we have the vaccine. There is no animal reservoir. Once we eliminated humans, it cannot be reintroduced. We have a, once in a lifetime opportunity to get rid of this virus forever. And so in 1967, WHO brought the world together to launch the Intensified Smallpox Eradication Program, to really roll out high enough coverage of this vaccine to eliminate it in every country in the world and finally to eradicate it. And now we know smallpox has been eradicated, but I just want to take this snapshot of the world in 1967 and say, what if the world had not come together for this? What if we said, well, there is no smallpox in the USA, there is no smallpox in the UK, we can live with this world. What if the world had said that? If we take those 2 million deaths and we increase them because the world's population has more than doubled since then, and we compare them to the other causes of death, smallpox would actually be the 4th largest cause of death in 2021. Only beaten by stroke, COVID-19, and ischemic heart disease. So this is the gift that the people in the 1960s gave us when they said, let's get rid of smallpox forever. The 4th largest cause of death today no longer exists. You might know the story. It took about a decade after that, but by 1979, the World Health at that time, it was called, the magazine of the WHO announced smallpox is dead. We had the members of the Commission for Certification of Smallpox Eradication sign this document declaring that there was no more smallpox in the wild. That means nobody ever has to have smallpox ever again. So this was a historic occasion in 1979. And at the result of this, the world saw what could happen if all the countries of the world came together, and that wasn't an easy job at that time. You might remember in the 1960s and 70s, the world was also divided as it was now between the sort of like the Western countries and the Eastern Bloc, between the rich and the poor countries, but all of them came together to say we want to achieve this. Soon after, WHO said, we've seen the success of this in eradicating smallpox. Actually, I have one more slide before I go there. I've said, smallpox, if it had not been eradicated, would be the 4th largest cause of death today. In terms of the value of smallpox eradication, economists have put together the cost of smallpox eradication. It cost about $300 million in 1967, sort of like currency, maybe $1 billion or so today. But the savings from smallpox eradication, if you count only the healthcare cost savings, they're about 70 million a year. So within 4 or 5 years, the cost of smallpox eradication is recovered if you only count the healthcare cost savings. If you could count what are called productivity costs, the fact that people who are sick, people who die, people who are, like disabled for the long term are less productive to the economies, that saves about $1 billion a year. So smallpox, this investment of 300 million is saving the world more than $1 billion a year every year. This is one of the greatest investments ever made. And in 100 years' time, we will still be reaping the benefits of this decision to eradicate smallpox. I hope, I hope we never have to see this again. So with this success, WHO said we can do even better than that. Smallpox has been eradicated, but actually, can we also do the same for many other diseases for which we have vaccines available? Can we control, maybe eliminate and eradicate some of these as well? So in 1974, WHO launched what was called the Extended Program on Immunization, which is really efforts to increase the coverage around the world, get more equitable coverage so that not only the rich countries are using these vaccines, but every country in the world is using these vaccines. And these are vaccines at that time against, the lines where you see in this graph start to go up around 1970s, 1980s. So basically it's BCG, it's DTP, which protects against diphtheria, tetanus, and pertussis, whooping cough. It's hepatitis B, and it's measles. Protecting against these diseases, these vaccines were introduced. And as you can see from these lines, from the late 1970s all the way to the late 1980s, you see a dramatic rise in global coverage from about 20% to 80%. Sort of like in the coverage of these vaccines. Then in the 90s, new vaccines started to be added to the EPI program because new vaccines were developed. So vaccines against Haemophilus influenzae, another cause of pneumonia, vaccines against pneumococcal disease, against rotavirus. Polio actually was in the original EPI. I forgot to mention, really important polio as well. Rotavirus, yellow fever. All these vaccines were also introduced into the EPI and have been life-saving. And so, here's a graph. I show a graph from England because there the records go back to a long time. You see, in the 1950s, something like 500,000 people would get measles every year. About, a substantial amount, maybe 0.5% or 1% of them would die. So there was actually a substantial death toll due to this disease. Then in around 1967 or 68, measles vaccine is introduced. And you can see immediately, you can see a dramatic decrease in measles incidence until, by the late 2010s, and the late 2010s measles, even has been eliminated for a while. It's a question of whether that will be sustained. But this is the power of vaccination. And this has been repeated in many countries in the world. So The reason I talk about the launch of the EPI in 1974 is if you do the math, you can see if you add 50 years to that, the year is 2024. Last year was the 50th anniversary of the EPI program, the Extended Program on Immunization, launched 50 years ago because of a vision that vaccines should be available to all the peoples in the world, not just the people in rich countries, but to everyone. And last year, WHO commissioned a group of modelers to actually look and see what has been the impact of the EPI program. And so you can see on the left, the launch of the EPI has saved has prevented something like 150 million deaths over the last 50 years. 150 million people are alive today, or well, have been alive longer, who wouldn't be if this had not been done 50 years ago. You can see on the left the change in infant mortality since 1974. And actually something like 40% of the improvement in infant mortality in the last 50 years is attributed to vaccines. That 150 million lives saved means that every 10 seconds, a life is saved by a vaccine somewhere in the world. Think about it. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And possibly, on average, someone's life has been saved. Someone didn't have to die because they received vaccines. This has been the power of vaccines. So the face of EPI is vaccinators all around the world. And some of these people are really heroes. I mean, I want to show this picture taken about 10 years ago by a journalist in Pakistan, because this was the day after a vaccination team was actually attacked and one person was killed by gunmen as they were giving vaccines. The next day, the vaccinators are there again, still giving the vaccines, this time with armed security guards. But this is how much they believe, vaccines save lives. Even at the risk of our lives, we want to give this life-saving tool to the people who really need it around the world. So it's not just in terms of lives saved. I mean, economists have looked at the value of vaccines. They do something called a return on investment analysis, where they say, for every $1 we invest in something, how much do we gain from that? So, if you invest in government bonds over 10 years, every dollar you invest will probably give you an extra 50 cents. So your $1 will become 150. If you invest in medical research for heart disease, $1 will eventually give you $5 back because you will improve, the lives of people who might have cardiovascular disease. Some of them will not die. If you invest in preschool education, you'll get $7 back. If you invest in community health workers, you get $9 back. These are great investments. We should be putting more into these things. But if you invest in vaccines, you get $16 back. This is one of the best investments you can make that governments, donors, agencies can make, investing in vaccines. $1 gives you $16 back eventually. It's not just on a national level. Vaccines have been said to be a sort of health insurance that everyone can get because they're an insurance against what's called medical impoverishment. So medical impoverishment means, the WHO and the UN have something they say it's the poverty line in every country in the world, and if anyone falls below that poverty line, they are said to be impoverished. Some people fall below that because they're impoverished through medical expenses. They have a disease and they have to pay a lot of money for either medical treatment, or even if medical treatment is free, they lose money because they cannot work, they cannot be productive, and then, often this results in them having to take loans, having to sell their assets, like maybe sell their fields or sell their cow or whatever it is, as a result, in order to finance these expenses. And it's worked out that actually, like every year, 100 million people are impoverished because of healthcare costs. They're driven into poverty because of these in immediate or wider healthcare costs, either the cost of accessing care or the cost of lost income as a result of sickness. But vaccines can prevent about 24 million of that, almost a quarter of the the medical impoverishment is preventable by vaccines, as you can see from the sort of table on my right. So even on an individual, on a household level, vaccines are not only saving lives, but saving people's livelihoods. But the story of vaccines didn't stop in, the 1970s. I said, in the 1970s, the EPI program was launched with these vaccines in it, the measles vaccine, DTP, polio, hepatitis, BCG, to protect against these deadly diseases. But actually, since the 1970s, many new vaccines have been developed. As talked about some of the vaccines against pneumococcal pneumonia, against rotavirus diarrhea. Some of the latest vaccines have been developed. A vaccine against malaria, a better vaccine against BCG is also in development. And as Dr. Fola said, we had the COVID vaccines just a few years ago. So all these vaccines have been able to save even more lives as new vaccines are being developed and added to immunization schedules. But there's also a challenge with all these new vaccines developed, and that is that the cost to introduce these vaccines is getting higher and higher. So this was an analysis done by MSF, Médecins Sans Frontières. They worked out that at the beginning of the 21st century, in 2001, giving all the vaccines that WHO recommended, not every vaccine available, just the one that WHO recommended for all countries, would cost 67 cents to fully vaccinate a child. But by 2014, the cost of this had risen to $45 per child because of all these new vaccines, which are much more expensive than the sort of EPI vaccines in the past. 45 US dollars at that time is more than the entire health expenditure per capita for many low-income countries. So how do countries afford these vaccines? They can say, let's just stick to the ones that we had since the 1970s. But actually, pneumococcal pneumonia kills thousands of people around the world. Rotavirus diarrhea kills thousands of people around the world. HPV vaccines, rubella vaccines, these cause many deaths, many disabilities around the world. So how can we say poor countries should not have access to these vaccines, right? So, so this was the impetus that led to the formation of a partnership called Gavi. At that time, the Gavi, the Vaccine Alliance, at that time, the Gavi Alliance. This was based on an observation. So this is looking at, for instance, a vaccine that was introduced in the 1980s, hepatitis B vaccines. So you can see as hepatitis B vaccine was first introduced in the 1980s, by the late 80s, a lot of high-income countries are already starting to introduce this vaccine. The first country introduced it in 1982. But if you look at low-income countries, the first low-income country only introduced hepatitis B vaccine in 1994, a full 12 years after the first high-income country. That is 12 cohorts of children who are not protected against hepatitis B. That is millions of children around the world. Why is that 12-year delay? And it's this delay, which is repeated for many other new vaccines that were introduced at that time. It's this delay which countries were saying, this is unacceptable. Why should, 12 more cohorts of children have to die in some countries just because they were born in the wrong country? That led to the formation of the Gavi, the Vaccine Alliance, which is basically a partnership of countries around the world, as well as private companies, vaccine manufacturers, to bring cheap vaccines to the countries that cannot afford vaccines. And so here's another graph that really illustrates the inequalities. I think Dr. Fola actually pointed out about the life-saving nature of COVID vaccines. And here's an article in the Financial Times that really illustrates it. So you can see on the top of the graph, the number of cases of COVID that happened in different countries. Let's look at the top, the UK. There was a big wave in, in July. This is the Delta. This is the the first wave of cases that happened, and you can see it was accompanied by a lot of deaths. But by late July, actually, a lot of people had started to be vaccinated. And you can see in countries like the UK, suddenly there are still cases because the vaccine doesn't protect everyone from getting COVID, but the number of deaths has diminished to almost zero. And that is the power of vaccination. By vaccinating all the vulnerable people, the deaths had been sharply cut. The cases were still there, but the deaths. You see the same in Portugal with high coverage. But then when you go to the countries with low coverage, with Namibia and Tunisia and South Africa, you see the same number of cases, but the deaths are still large. The deaths mount due to low vaccine rates. So this is again the inequality of vaccines leading to unnecessary deaths around the world. So the purpose of Gavi was really to address this issue by three means. The first is through donor contributions, actually richer countries actually paying into Gavi so that the money can be spent on buying vaccines for poorer countries. The second approach is by reducing vaccine prices, really by saying, well, Gavi is going to buy vaccines on behalf of many countries in the world. So they're able to negotiate with manufacturers and say, actually, let's reduce the cost of these vaccines. We can guarantee, we are going to buy hundreds of millions of doses from you. Can you give us a better price so that more countries can afford this? And third is gradually increasing country co-financing so that as Gavi gives vaccines to poor countries, as they start to get richer, they take over some of the financing of these vaccines until when they stop becoming low-income countries, they take over fully the cost of these vaccines. So bringing them to a transition so that they can gradually pay for the vaccines themselves. These are the three roles of Gavi. And over the last last two decades when Gavi has been around, Gavi has been responsible for introducing many vaccines in the poorest countries in the world. When it was set up at the beginning of the century, really it focused on 4 vaccines that were not in the EPI schedule, but was life-saving. So pentavalent vaccine, which is the DTP vaccine, but also includes protection against Haemophilus influenzae, the hepatitis vaccine, Haemophilus influenzae, and then the yellow fever vaccine as well. And so over the time, as new vaccines were developed, Gavi has been able to introduce sort of more vaccines to the schedule. I mean, the most recent rounds were in the most recent sort of like vaccine investment strategy. Every 5 years, Gavi considers the vaccines it's going to support. And the most recent round really concluded that Gavi would support the introduction of now vaccines against RSV, against tuberculosis, newer vaccines against Group B streptococcus, and also against dengue, as long as we get better burden data, especially in Africa, because we are getting many reports that there are huge outbreaks of dengue, but actually there's not enough burden data to really understand the disease burden. So so many new vaccines have been able to be introduced over the last 20 years through the efforts of the world coming together through Gavi. So how does Gavi decide? I mean, not every vaccine is in its schedule. Some vaccines have been, still save lives, but Gavi has decided, no, we can't afford this. So what Gavi does is to go through actually a vaccine investment strategy process by which it actually gets information from WHO. WHO conducts a landscape analysis and says, these are the vaccines that are in the pipeline that will be useful. We should keep an eye on this. Gavi takes this as its long list and then goes through a whole series of evaluations of disease burden, demand in different countries, feasibility of introduction, impact, cost effectiveness. So lots of modeling involved in this, looking at and also other important dimensions like equality, social justice, global health security against pandemics or against AMR, and taking all this together, really scoring these vaccines and deciding to fund the vaccines that come out with the higher scores as a result. So I'm going to stop here, but I'm going to end with a couple of key messages that we've heard about. First of all, as we've heard, vaccines have saved millions of lives, 150 million lives saved because of the decision to launch the EPI program to say every country should have access to these life-saving vaccines. In fact, many analysts have said, vaccines have saved more lives in the past century than any other health intervention apart from clean water. And the story has not ended. Many new vaccines have been developed and new vaccines are in the pipeline. There are still diseases where there are not yet effective vaccines against them. But not all of them are affordable to the poorest countries in the world. So really, the only way vaccines can have their maximum impact, especially in the countries with the highest burden of disease, is through global cooperation, through WHO, through Gavi, through different organizations that can bring this life-saving technology to the people who need it them the most. Okay, these are my messages. I'm just going to end by one more story. I know I'm based in New York. My colleagues from the UN who invited me to give this talk are based in New York. Well, for those of you in America and indeed around the world, it's worth thinking about, about 50, 70 years ago, many of these vaccines that we take for granted in the US and in countries around the world were not yet available. In the 1940s, polio was a terrible disease that put thousands of people in disabilities. People had to be put in these huge machines called iron lungs to keep them alive because they were unable to breathe without them. In 1955, a vaccine against polio was, developed by Jonas Salk, and people were so ecstatic about it that businesses closed, shops closed to celebrate on the streets. People put up notices to celebrate this. Church bells were ringing throughout the country. This was how much a new vaccine was celebrated at that time because people knew, how terrible diseases were and how powerful vaccines could be. The same miracle is happening every day today. People are getting vaccines against polio, against measles, against diphtheria, and their lives are being saved in the same way. But it's easier to take it for granted now because the vaccines have been around for a long time. We hardly see the diseases at all, and I hope that we never see it. We never see them. But actually, we need to recover, I think, that same spirit of celebration that was there in the 1950s, not just in the US, but in countries around the world as these vaccines were being introduced to say, this terrible disease that people feared, we no longer need to fear it because of vaccines. So thank you so much for the opportunity to talk to you. I'm happy to answer any questions that you might have.
Thank you so much, Professor Jit, for this wonderful presentation. I mean, you really went on it so hard, and you gave us all the nitty-gritty of what we're supposed to know. Thank you so much. I mean, the one that caught my attention was when you said that the EPI program alone has saved more than 150 million deaths. Imagine that is just a program alone. We're not talking about other vaccine programs and whatever. I mean, so which means it's actually like we have all the evidences around us that vaccine works. And my colleagues, if you have any questions, please do drop them in the chat box. Professor Git will be able to answer all those questions. We will read all those questions to him. While we are waiting for your questions, I have some questions that I will ask him here. The first question is this: how do you quantify the economic benefits of vaccine beyond just healthcare saving?
Great. Thank you, Dr. Fuller, for those words. And yeah, that's a great question. So there are many different economic benefits you can get from vaccines. And as you said, one is the healthcare cost savings. A second is actually the fact that we're saving someone from dying or having a disease. So people don't want to be sick because healthcare is expensive. But people don't want to be sick because people don't like to be sick, right? If I told you, you can get the flu and I'll pay for all your expenses. If you miss work, I'll pay for you. So would you like the flu? You'll still say, no, I don't want to have flu, right? I don't want to have measles. I don't want to have, cancer or whatever disease it is. So the value to people of not getting sick, not dying, that's also worth value. But there's also the productivity value. If people are sick, they are less productive. productive in the economy. So they can't work, they can't take care of their children, they can't, do like household work as well. So all this can be given a value based on things like the income that people earn, or the income that they could be earning. Caregiver work is not paid, but that is valuable work as well. So all these things that people can't do is given a value as well in the economic analysis. Yeah.
Okay. Thank you so much for this response. Somebody's asking a question in the chat, said, is there any recommendation from Gavi regarding the current dengue vaccine to be included in the official country's vaccination program?
That's an important question. So Gavi has in its recent VIS said that committed to funding dengue vaccine in the Gavi eligible countries, but only if there is burden data especially from Africa, because the problem is there are a lot of indications that there's there is a big dengue burden in Africa, but not enough data being collected to identify where. And the majority of countries that Gavi supports is now in Africa. So right now, what needs to happen is those studies to look at the burden of dengue in Africa, which has really been not studied well enough. The data have not been collected. The focus has been on malaria, but dengue is probably also a very big problem. And Gavi will say, once that data is there, they know which countries really need it. They will release the funds. They will bring the vaccines to those countries.
Okay, thank you so much. The next question is this. In one of your recent publications, you examined the challenges in ensuring global access to COVID-19 vaccines, specifically in regard to production, affordability, allocation, and deployment. In general, what do you think is the largest barrier for vaccines?
Well, I think COVID. Oh, sorry, go on.
Go ahead, please.
Yeah, okay. I think COVID is a very interesting and informative case. On the one hand, you could say it's a success story. I mean, for COVID, there was an initiative called COVAX, which was, the purpose was really to purchase vaccines at a low cost so that different countries could afford it. And, like when I showed you the graph for hepatitis B, it took 12 years for the first low-income country to introduce it compared to the first high-income country, right? So for COVID, the gap was only about 12 months. So COVAX was successful in really narrowing this gap. On the other hand, you could say COVAX was not a success. It was a failure. Why was that? Because those 12 months during a pandemic was millions of lives, like I showed from those graphs. 12 months was too late because by the time the vaccine was introduced in many of the poorest countries in the world, most people had already been infected. A lot of people had died. And so the vaccine was actually less valuable because the first infection that people get is the most serious. And, most high-income countries, people managed to get the vaccine before their first infection, or at least before the first Delta infection, which was very severe. In low-income countries, that was not the case. So I think the COVID experience says, COVAX initiative like that are very important. They do make a difference, but we need to do better the next time. We need to have, not that 12-month wait, not some countries saying we'll buy out the whole stock and COVAX can have what remains. But actually, maybe we need more manufacturers around the world as well, more production capacity in different parts of the world so that, there'll be more local manufacturers. We need to think about how we can do this better. So I think it's a step in the right direction, but it's not enough by far.
Okay, thank you so much. I have one question for you from the chat. It said, what were the key factors that contributed to the success of the smallpox eradication, and how did those successes influence vaccination strategy for other diseases?
Thank you. That is a great question. And I think there's two sets of factors. One is, I think, what I'll call the sort of health or biological factors. The fact that smallpox was easier to eradicate. One, I said it has no animal reservoir. If you get rid of it in humans, it's gone. Second of all, everyone with smallpox has symptoms. So that's one of the challenges. Now the world is working to eradicate polio. And, we are quite close to that. But one of the challenges with polio is many people get polio but don't have symptoms. So they get it and they transmit to others, but it's not detected till later on. With smallpox, we didn't have that problem. And it has a low, what's called, R naught, the reproduction number. So it doesn't spread so quickly compared to something like measles, for instance, which has a very high R naught. If 10 people have not been vaccinated and you put one person with measles in the room, most of the people will get measles. That's how transmissible it is. Measles spreads very fast. So those factors, but I think besides the biological factors, there were also, I would say, the political factors. The fact that, in the 1960s and 70s, in the height of the Cold War, all the countries in the world came together and said, we don't care which bloc you're in, we don't care, which country you're in, everyone agrees that this is a disease we want to get rid of. So all the countries in the world came together to make this work. If countries can't come together like that, we can't eradicate a disease, because as long as it's around in one country, the whole world is still vulnerable.
Thank you so much for that response. Somebody is asking this question. I will just read it the way it is. I mean, are prices of vaccine too high? What about antitrust and competition rules? Are they applicable? Is there a human right to vaccines?
Yeah, well, I mean, the WHO Constitution says that, people have a right to health, the highest level of health. And, in order for them to have that health, vaccines are needed. So I would say there is a right to vaccines in that sense. I mean, in terms of antitrust and competition law, I think this is complicated. That's a lot of legal and economic issues involved. But I would say, without going into the exact mechanism, I would say that there is a mechanism to, bring access to vaccines around the world. And that is the fact that, okay, private companies, they spend a lot of money developing vaccines, and we know we can't then ask them to give it for free because they won't develop any vaccines. But their business model is based on, higher prices in countries that can afford them. So a new vaccine in the US or in Europe, that these countries will pay a lot of money because they get a lot of value from these vaccines. And that covers the cost of the R&D for the companies. The marginal cost, the cost of producing one extra dose, is very low. So once they've covered their R&D from high-income countries, they can actually sell these vaccines for a very low price in low-income countries. The challenge is to, be able to persuade the companies through mechanisms like Gavi and other mechanisms, not to wait till they've made all the money back for the R&D from high-income countries, and then maybe 5 years later or 10 years later say, okay, now we can reduce the price for poor countries because we've got back our R&D costs. But to say, actually, we will get back the R&D costs. Let's give it to poor countries right away so that they can afford it from day one, not day 1,000 or 2,000, so that, these generations of children don't have to grow up without having this vaccine protection.
Thank you so much. The next question is this. Vaccine hesitancy has become a major public health challenge. How can economic modeling help address this issue?
Right. Well, that's an interesting question. I think, the vaccine hesitancy is really a challenge now. And I think part of it is really because vaccines have been so successful. So, as I said, if you go back to the 1950s, you don't have to tell people polio vaccine is safe and effective. They are queuing up. They are celebrating when the polio vaccine appears. They are having holidays because they're so happy. The same for measles vaccine, when it's introduced. The same for vaccines against diphtheria, because people know they are deadly diseases. Now people never see these diseases again, except in, some countries in the world. So people take it for granted. But we don't want to go back to a place where people have to worry about these diseases again. So I think there is a lot of work in terms of really understanding the reasons for vaccine hesitancy in communication, in engagement, because most people who are vaccine hesitant, I don't mean the very strong anti-vaccine movement, but most people are vaccine hesitant. They just want more information. They have heard different sort of accounts, and they want to know what's the truth. So we need to engage, we need to understand, we need to hear how people are making decisions and get into those conversations. So I think that is not really about economics. That's about human communication, about understanding, people and working with people and where they are. From an economic point of view, I think it's very easy to, on a national level, on a policy level, to make the case that actually vaccines are a very, very good investment. But in order to get the full value of vaccines, we need high coverage. We need what's called herd or community immunity, in order to protect everyone, including the vulnerable people who might not be able to get vaccinated because they are immune compromised, so the vaccines don't work so well against them. We need very high coverage. Otherwise, the infection will still spread in the population. So that's what the economic models will say.
Thank you so much. I have a question for you from the chat. So why are some vaccines, why some vaccines were discovered in the 1980s or 1800, and they are not yet introduced in immunization calendar of many countries? Let's take, for example, anti-typhoid, anti-rabies vaccines. Why are they not in some country immunization calendars?
Yeah, that's a very interesting question. I think some of these vaccines are not sort of like, well, a lot of these vaccines are recommended by WHO. I mean, rabies is not not highly endemic in many countries in the world, so not many countries have introduced it. But there are some countries where it is, it is an issue, and some of them have rabies vaccines, some don't. And partly it's because, like the cost of vaccination, some countries, it would save lives, but countries can't afford it. With typhoid vaccine, this is really a vaccine that, like WHO and others are really recommending countries with endemic typhoid to introduce, because there have been the traditional typhoid vaccines that have been around for a very long time. Those did protect people, but not so effectively. But now with the new, typhoid conjugate vaccines, there are very effective vaccines against typhoid. And so, we're starting to get more uptake of these vaccines. But yeah, again, it comes to things like costs again. So we really need more financing in this area as well. Yeah.
Thank you so much. The next question I have for you is this. During COVID-19 pandemic, model played a huge role in shaping government responses. What were the biggest lessons learned from that experience? Were there miscalculations? And did certain countries use models more effectively than others?
That's a great question. And I think, yeah, models were very influential, but also controversial in many countries in the world. And I think what we've learned from that is, the way to use modeling. I think modeling was incredibly important because it's basically intelligence. It says, what is going to happen so that governments can be prepared. If different options are taken, what will be the consequences? But I think the way to use models is not like, people call a crystal ball. You go to the ball and it tells you, oh, this is what the future is like. You go away and you make your decision. The way to use models is part of a whole committee of people who understand different aspects of the problem, epidemiologists, virologists, but also people who, represent patients, the public, to say, you can say, let's like close schools for 3 months, but that, you're going to destroy people's education, you're going to destroy people's livelihood if you do that. So we have to find some balance. We have to protect people's health, but we also have to take into account what's happening, on the ground. So I think countries where we had, people coming together, looking at the modeling results and then debating them from, the human impact, the epidemiological impact, the virology of the disease, and then being able to, interact with government policymakers with all these factors, they were able to make some very good and also widely accepted decisions. So yeah, I think some countries were quite successful in using models actually to guide. I think, having very tight restrictions at first to keep COVID out of the country and not letting it spread. And then as vaccines began to be introduced, then being able to release restrictions. Yeah, it was also challenging in other countries. Every country has its own situation in terms of, the state of the economy, the livelihoods of people, ability to work from home. If you're a farmer, you cannot say, or, you're a shopkeeper, you cannot say you're going to work from home. But if you're, an accountant, you can. So the state of the economy, the access to vaccines, the like the population, like the demography and so forth. So there's no one size fits all solution.
Thank you so much for this response. Another question from my side is this. So going forward, are there any latest technology expected for vaccine development? During COVID-19, most of the vaccines were newer vaccines being developed using new technology. So do we expect more of this?
Yeah, I think, the vaccines really showed the success of some of the new technologies that were being kept, like sort of like they had been used for other vaccines and medical technologies in the past, but not in such a big way. Like, for instance, mRNA technology, viral vector technology. And during the COVID sort of pandemic, both through the clinical trials that were done and then through the rollout, it showed that actually these technologies work very well. They produce effective and safe vaccines. So that's good news, because it really opens the door for many new vaccines to be developed using these technologies. And these vaccines might be, like more effective than previous vaccines. They might be vaccines that can be developed faster. So we have a new emerging infection that, we don't have vaccines against, the vaccines can be brought to the to people to save lives more quickly.
Thank you so much. 1 minute, let me check here. Okay, looking forward or looking at the future, what vaccine preventable disease do you think global health efforts should focus on next? And is there a neglected disease or pathogen that doesn't get enough attention in global vaccine policy?
Those are really great questions. I would say the question really captures the answer. I think on the one hand, there are the big diseases. I mean, you probably know the three big infectious diseases: HIV, malaria, TB. HIV, there's no vaccine. TB, there is BCG, but which works, is life-saving, but not as effective as we would like. And there are new vaccines in the pipeline. Malaria, we are starting to see, like vaccines have been introduced, and a pipeline of more effective vaccines. So I think these are the three big ones, where as we get, hopefully more and more effective vaccines, these can really be game changers. I think, but on the other hand, there are the diseases that are called the neglected diseases, which maybe don't have so many cases of death around the world, but still have a high burden, but maybe a neglected burden because the burden is in poor countries and in the poorest populations in those countries. And that's the area where there's not much research, not much development going on. Like maybe schistosomiasis, for instance, the vaccine pipeline, it's not a very crowded one, because you really need some extra, like financial incentives for these vaccines to be developed. So I think you captured it on both sides. We need, like more work.
Thank you so much. One of my questions that I was trying to avoid, maybe I should not go there then. Suddenly somebody asked in the chat. That was my last question, but I was like, maybe I should ask or I should not. But somebody asked in the chat, then I will read it now. Is there any research going on new vaccines with support of artificial intelligence?
Great. Well, that is a big question in almost every field, right? How will AI sort of improve things? I mean, there's two parts of this. One is on the, vaccine discovery and development and so forth. That's the area I know less about, but I know that AI, machine learning, is being used, and I think successfully, to actually speed up the process of the sort of discovery of the right, molecules and so forth. But I don't want to talk much about that because it's not my area of expertise. I think in terms of understanding how vaccines work on the sort of side of the, the models that are being used to understand how vaccines work, I think AI is starting to help to speed up the process of coding these models, of, like searching the literature for these models. So it's still early days, but I think we will see, AI being used to help. And also in terms of surveillance, in the past, when you get case reports in many different formats from the field, it takes a lot of time for people to then take them and input them and standardize them. I think AI is starting to be used to help to streamline this process. So there are some real developments that can really help the field. I don't think we will see, well, I can't predict the future, but at least with current technologies, I don't think we will see with current technologies a situation where you just take a bunch of data, throw it in a computer, and the computer just gives you the answer and says, tomorrow you should do X, Y, Z. And I don't think people will trust the computer even if it did that. But with human beings doing it, but their work sped up by AI, I think that can do really a lot of things to help us.
Thank you so much. The last question here is where I can throw it to you or I can answer it. So we are seeing obesity becoming a global problem. Any vaccine around this? What I can say is, from what I know, Prof can add to it. There has been a lot of development in this area, but most of the vaccines are still undergoing a lot of clinical trials, and none of them has been brought to the mainstream clinical usage yet. So a lot of research going on around this to see what is obtainable, but most are undergoing a lot of trials now. So let's wait and see if something will come up in the future. Prof, what do you think?
Yeah, that's a great answer. I mean, I know that a lot of attention is now in not my area, but on obesity around the GLP-1 agonists, and those seem to be making a big difference. But again, it's a matter of access. The prices are super high. So, again, we will need to address the question of access.
You see, thank you so much, everyone. You could see vaccine access, equity is just something that we just need to balance. A lot of misinformation that leads to hesitancy. These are the things that we need to address, and we'll keep addressing it. I think those are the questions that I have finally for today. It's been wonderful talking to you, Prof. Thank you so much for the presentation and for answering all our questions. We appreciate your time and your knowledge that you have shared with us. Thank you so much. And hopefully in the future of this program, we'll still bring you back to come and talk to us on some other very interesting topic. Colleagues, wherever you are located, thank you so much for participating also. Thanks for asking those wonderful questions. And then we'll see you soon during the next episode of our Public Health Conversation series. Thank you and have a wonderful day. Thank you. Bye-bye.
Thank you so much. It's a privilege to be here. It's great to be able to interact with everyone. I'll see you all.